Good evening, everybody. Today, we would be having a panel discussion on recurrent implantation failure after PGT. The experts today are Professor Chi from Taiwan, who is the founder and CEO of Taipei Fertility Center and honorary professor at the Taipei Medical University. Currently, he is the secretary of Asia Pacific Initiative uh, of Reproduction, that is ASPIRE, founder and honorary president of the Taiwan Endometriosis Society, founder and CEO of Taipei Fertility Center, honorary professor at the Taipei Medical University, board member of the ASFP as well as the ISFP. He has also held several other posts before this, prestigious posts before this, and he has several papers to his credit. We then have Dr. Nalini Mahajan, who is the director of Mother and Child Hospital, New Delhi. She has been the president of the Indian Fertility Society as well as the Asian Society for Fertility Preservation. She is the board member of the International Society for Fertility Preservation. He has several publications to her credit and also been the past editor-in-chief of the Onco Fertility Journal. And we have Dr. Keshav Malhotra, who holds a master's degree in clinical embryology from Monash University, Australia, and is one of the few HRA certified clinical embryologists in India. He's a lab director of the Rainbow IVF and now the director of Malhotra Embryology Training Academy. Dr. Malhotra is the vice chairman of embryology for ISAR and also chair of SIG Embryology Aspire. He was also selected as one of the HRA's 5 for the year 2021, and he has also been recognized as the budding embryologist of the year by the Economic Times of India in 2019. Next slide. Yeah. So basically, we would now start with the discussion. So we know that implantation is a complex process which requires basically a euploid embryo and the endometrial lining in a state of readiness for implantation. But today, what we are going to discuss is implantation failure in those patients where an euploid embryo has been transferred. We know that there have been several definitions of RIF. I would like any one of you all who could define RIF now, because they say that if you transfer 3 euploid embryos, usually the implantation rate could be as high as 95%. But still in our practice, we see a lot of patients who come with implantation failure. Dr. Nalini, can you?
I was hoping you would ask Chi this question because, there's so much confusion around the definition of recurrent implantation failure that, it has left us completely confused. So it started with 2 failures with 4 good embryos. Then it went on to 3, certain sects believe that it was 3 failures. And then we should call it recurrent implantation failure. And now HRA has complicated it so much more, saying that, there's an age cutoff below and above 35. And below 35, even when you have non-biopsied embryos, up to 6 embryo failures, after that only it should be considered RIF. And for euploid embryos, 3 and over 35, 2 euploid embryos fail, and it should be considered RIF. But my contention is that even 1 implantation failure is a disaster for a patient, because patient is not a statistics. Now, when we define RIF, it is that, okay, now we have defined RIF and therefore we need to get on with certain investigations which might help us to define this multifactorial issue. But maybe to my mind, what is important is that even after 1 implantation failure, the basic investigations maybe should be done. And after 2, maybe we can go on to a slightly higher level of investigations for implantation failure, because we all know that when we evaluate the patient to begin with, We have already evaluated the endometrium. We have already evaluated for anatomical defects. We have already evaluated for thyroid profile. The endocrinological part is always a part of the basic evaluation. Sperm is a part of basic evaluation. Maybe we don't do a DFI in every patient, especially who are non-smokers. So certain investigations, I feel, should be done even when we have one failure. Basic investigations should be very comprehensive, and then maybe a higher level of investigations when a patient has two failures. I think if you have a higher age, then even after one euploid failure, we should consider looking at other aspects.
Thierry, do you want to add anything else? He's also told us what would you like to add, or would you like to go on to the causes of RIF after they've transferred the employee embryo?
I think he hasn't heard you.
Thierry, would you like to tell what are the causes of RIF after we've transferred a euploid embryo? I'm hearing. Yeah.
I think the majority of implantation failure may be due to the embryo, but now we exclude because all the embryo are euploidy. So we must pay attention to the other factors such as the endometrium or the uterine factors. So I think the hysteroscopy is very important because it can rule out all the uterine abnormality, like intrauterine adhesion, or some polyps, or some mucous membrane. All this we must exclude. But also, endometrium lining, I think all agree, should be greater than 7 millimeters in thickness. But sometimes they are not reaching this category, this criteria. So how to improve to increase the thickness, also very important. The other thing, the hysteroscope also can rule out the chronic endometritis. Sometimes the infection is not easy to implant. And it's easy to use hysteroscope to rule out because all the biopsy tissue of the endometrium, you can easily to find out plasma cell inside. So that is the uterine factors we can with. The other thing is the receptivity. For endometrium, the receptivity is very important, especially the window of implantation. But for the embryo, that is selectivity. For the endometrial receptivity, I think the test such as ERA or some other method, like easy to identify the window of implantation. But unfortunately, 2 years ago, the American Society of Reproductive Medicine, especially from the Shelley group, they published a paper say, oh, it's not important. But in my experience, my studies, when patients reaching over age 40, the window of implantation seems to be a little bit delayed. And I talk this issue to the IVI people. They also agree because when patient age over 40, or the endometrium or the mitochondria, the growth of a little bit delayed. So I still think the ERA test is also very important. And then you look at the group from US, they published in JAMA in 2022. When you look at the patient, they are all very young. They have two arms. One arm is 350, the other control arm is 350 patients. But the patient is average 35. So the young patient, of course, the endo implantation receptivity will be no change. So we consider if the patient is old patient, you must do ERA. That is, and our finding, we collect 169 patients, also prove the same finding. When patient getting old, the window of implantation may be delayed 1 day later. And I talked this to Carl Simon from IVI. They all agree. He agree my point. So that is the endometrial factor as we must pay attention to.
Well, basically, when you talk about chronic endometritis and you see identification of plasma cells, I think it's quite difficult like that to really get them on histopathology. And many a times we treat these patients empirically, just looking at the appearance of the endometrium.
Usually you see the strawberry-like. It's very different from the normal endometrium. And usually in cavity, strawberry-like a little bit, some very typical pattern. So I think it's very easy to make a diagnosis. Of course, the biopsy is confirmed the diagnosis.
So you have to do a immunohistochemistry and look for the CD138 cell. On a normal histopathology, you are not going to identify the cells. So not everywhere it is possible to do that, but on hysteroscopy, you can suspect the diagnosis. Sometimes even you can be reasonably sure that it exists. But I just wanted to put one observation here in front of you. I was just, wondering that what about the fertile women? How many of them also would show CD138 positive if we looked at their endometrium? And, we looked at about almost more than 30 donors now who are donors and surrogates, so fertile young women. And we had the same incidence of CD138 cells being positive in them as compared to the RIF or the recurrent implantation failure. So sometimes you worry that, are we just going on and on with a lot of testing, and in what particular group would it really be relevant to do the treatment?
What other causes do you think also could lead to RI? So I think a proper embryo transfer is also important, I think, under ultrasound guidance, because if you have people who don't have that much experience and the embryo is not deposited properly or not done under ultrasound guidance, also may make a difference. Do you think any other factors like endometriosis, adenomyosis, hydrosalpinx would affect?
In adenomyosis, definitely what we find is that the window of implantation is altered, and we have, had reported on this, and recently again there was an article which shows that the window is delayed in patients with or altered in patients with adenomyosis. So in those patients, it's really important to do ERA test. And the other thing, if you down regulate and do a slightly long down regulation, it helps to reduce the inflammatory markers and perhaps improve the Th1 Th2 balance within the endometrium and allow for better implantation.
Keshav, other than the euploidy of the embryo, what are the other lab factors which would result in recurrent implantation failure?
Ma'am, there are a lot of different factors that can actually affect implantation, and this was studied by Simadomo, and I had the privilege to do a podcast with him for Aspire as well last month. Now, he basically looked at 13 embryonic factors, and out of which, if we look at the important ones which showed significance, uh, positive correlation was seen with vitrified embryo transfers. So there was a positive correlation with frozen transfers, and there was also a positive correlation when doing the biopsy itself. If the zona pellucida was opened on the day of biopsy, there was a positive correlation towards the implantation. When you look at the negative factors, it was the grade of the embryo. So inner cell mass being grade C, trophectoderm being grade C, definitely had a negative correlation. Even if the blastocyst was less than BB quality, there also the odds ratio was 0.4 towards the negative side. If it was a day 6 or a day 7 embryo transfer, again, as compared to day 5 transfers, it had a poorer correlation. And if it was 2 vitrifications for the same embryo, then also we had a negative correlation. So these are all certain factors which we can actually look at when we're choosing embryos for transfer for the same.
I think when we are doing an FET, we should not thaw more embryos and re-vitrify them. I think we should just thaw them number of embryos we really want to transfer.
Yeah.
So in your lab perspective, how would you go about looking for what factor really affected?
Ma'am, we generally start with, let's say I have a patient who's undergone a biopsy cycle. After this, we generally choose our embryos based on the grading of the embryo. So first priority is always on the morphology grading post biopsy. Second priority is based on the post-thaw quality of the embryo. Certain times post-thaw, if the quality is not sufficient, or even during the vitrification process, sometimes we feel that the blastocyst has come out of the zona pellucida, we might deprioritize that for transfer. Um, Again, as far as lab factors are concerned, quality control, all of these procedures, keeping the VOC levels low is of importance for us. There are certain cases where we would use embryo glue for transfer. That's also showing there's one RCT for RIF, which is showing a positive correlation for using embryo glue for such transfers. These are certain things that we do for this
The air
particular.
quality of your lab also affect, and how would you test that?
Sorry, can you please repeat?
Air quality of the lab, does it affect, or
Absolutely.
would you test for that? And I think,
Absolutely.
regular doing cultures and maintaining the right quality and checking for the air quality is also important.
I 100% agree with this statement. We need to monitor our VOC levels on a regular basis, and also the particulate matter on a regular basis. We know for sure now that if the VOC levels are above zero point 0.5 ppm, in those scenarios, there is a higher incidence of miscarriages that happen within the clinic, which could also be, there could also be a higher incidence of RIF, which though undocumented, but I'm basing the statement on the rate of miscarriage that happens. So keeping air quality in check is important. It also affects the quality of the embryos that are developing within your laboratory. So you might get more fragmentation if air quality is not well maintained. Other things that we look at as exposure levels, we try to keep it low. Uh, can use time lapse if you have time lapse in your laboratory, just to control these certain parameters. Changing of filters, cleaning, doing regular cultures every month. The start of the month and the end of the month, we'll do cultures for contamination. These are certain things that can be utilized to monitor the quality of the culture condition.
Do you think an air handling system should be there in every lab, or it's not essential?
It depends on the size of the laboratory. Now, if it's a larger size laboratory, having an air handling unit with a certain amount of air changes is essential. If it's a smaller, let's say it's a 10 by 10 lab, in those scenarios, having a air purifier, a lab grade air purifier would be sufficient. We also want to maintain positive pressure within the laboratory, and that's where these air handling units actually come into picture. And it's important that when you're putting an air handling unit, the air handling unit of the laboratory and the adjacent OT are separate, so that that pressure gradient is also maintained. Pressure grade for maintaining pressure gradient, again, opening of the door should be outside the laboratory so that no air from outside enters into the lab. We also want to control the embryologists who are entering the lab. If they are using any cosmetics, etc., that should be avoided. Any thing that will generate VOC within the laboratory should be restricted as much as possible. Obviously, this, like everything generates VOCs, and there are things that we cannot restrict. But if you have this mindset that you are wanting the best quality air within your laboratory, then you start checking those boxes of what can be brought into the laboratory, what cannot be brought into the laboratory, how many people working in the lab at the same time.
In your experience, Keshav, if Madhuri, can I just ask?
Yes,
Yeah,
ma'am.
yeah.
In your experience, what has worked for you in the patients of RIF that you do? What do you do in the lab which you feel has impacted?
Ma'am, currently I am seeing a positive trend towards use of embryo glue. That's something that I have now started using for a lot of cases in my clinic. And when I compare my results from the previous years, there is a positive trend towards pregnancy rate. I'm still yet to analyze live birth rate, but that's something that I feel is working for my patients.
So just
Obviously,
yesterday, we had a discussion on embryo glue,
yeah.
and Dr. Fatimi's unit in Abu Dhabi has done 100 euploid transfers with embryo
Yeah.
glue and have not found any difference at all in implantation rates. So the biggest problem is that all these things really, some people say that they have a good experience and others don't, and at the end of
No,
it, we don't know exactly
and
what we should do.
I don't have the same amount of numbers for euploid transfers as Dr. Fatemi has. So in our scenario, it's more for general transfers where we've seen a positive correlation in our self fresh transfers for our patients. So that's something that has also been reported in the meta-analysis that has been considered for embryo glue in the recent RIF guidelines. We're seeing the similar trend here. But
How would you
in
invest?
cases of frozen transfers and in cases of egg donation cycles, there is actually no difference. And I would consider the PGT also to be falling into the frozen transfer category.
So, Chiri, how would you go about finding the cause? How would you investigate this patient?
Hmm, The I think the implantation value we talking about. I agree. The Keshav's point, day 5 is better than day 6, because when we look at the octa4 in the inner cell mass and the gata3 in the trophectoderm, it's different. In day 5 embryo, the octa4 is highly expressed compared with the day 6. So that means the quality of the day 5 blastocyst is better than day 6. The other, we're talking about the hysteroscope, talking about the endometrium thickness. As sometimes the endometrium thickness pattern is more important than the thickness. I have one patient, 49 years old. She had only 5 millimeter in thickness, but triple line, only 5, not 7, triple line, 49 years old. No matter how you use any kind of estrogen increase dose, still 5. So then we give the progesterone, and after 5 days transfer, she get pregnant. So pattern, endometrial pattern is more important than the true thickness. That is my some experience. And also we can use some growth hormone. Because growth hormone, they can produce IGF-1 in the liver, and they also induce some beneficial effect of the endometrial growth. So just short, start from the day 2, day 3, just 1 or 2 shots from the very beginning. You see the beautiful growth of the endometrium of the treatment compared with the previous cycle. So probably that's we can do. Also, we talking about the microbiome. Especially lactobacillus. And we discover the lactobacillus, especially Crispara and Inus. Some species are beneficial for implantation. So maybe we can supplement with this patient with their recurrent implantation failure. And Nalini also talking about adenomyosis endometriosis, because in patients with adenomyosis, those patients usually have very high serum CA125, which is an inflammation markers. So in those cases, we treat the patient a GNRC analog 1 or 2 months, try to low down the serum CA125, and then do for transfer. Then we can see the pregnancy totally different. We can increase the pregnancy rate. Very similar in patients with endometriosis, because when you do the laparoscopic examination for those patients with endometriosis, usually see the serosanguinous peritoneal fluid, bloody peritoneal fluid, which contain abundant iron, and iron they can go through the Fenton reaction, create and generate many reactive oxygen species, which is detrimental. So again, for those patients with confirmed endometriosis, abnormalities, 1 month, 2 months before transfer, GNRs is very useful.
What is your opinion on sequential transfer, Shri?
Yeah, that is a segmental. So you oocyte retrieval first, frozen the blastocyst, and then GNRH 1 or 2 shots. And then afterwards, we do transfer. So segmental treatment for
No. I wasn't talking of that. I was talking of sequential, the one embryo on day 3 and then one on day 5. So from Israel, there are a lot of papers on sequential transfer. And in fact, Ariel Weissman once told me that it works very well. And I have been using a lot of it, and it does seem to have an advantage, especially in patients, where the simple single embryo transfer has failed.
I do not have this experience, but this method is you double the number of embryo transfer, right? You transfer two,
Yeah,
not
two.
one and
Two
one.
embryos, basically one on day 3, and it probably gets the embryo endometrial crosstalk going, and starts favoring towards a Th2 change. That is my presumption. And then when you put the day 5, it's more or less ready. Because what we observed, one was that the pregnancy rates are definitely higher. Two, we invariably have only the implantation of one embryo. The day 3 one doesn't really, in a very small percentage it may implant, but mostly it is the day 5 one which implants. So my presumption is that that first one starts off the dialogue and then maybe alters the receptivity or improves the receptivity, so that when you're putting in the day 5, it has a better environment to implant.
I think
Just
we need more study.
theoretically, I'm speaking.
We need
But
more
yes,
study.
the results are very good with the sequential transfer.
Keshav, do you have any experience with sequential transfer?
We
Unmute.
also have looked at sequential transfers versus blastocyst transfers. I don't have a positive or a statistically significant difference between the two, but like mom really chooses these RIF category patients, and we do sequential transfers in those patients, and the results are pretty good. I would definitely agree with Nalini ma'am that we also have a high pregnancy rate in this particular subset of patients. But I don't have an explanation for it.
So Chiri, there's a question that was asking whether you do a intrauterine growth hormone or it's the IM growth hormone.
Say it again.
Yeah, is it the intrauterine growth hormone you use or the intramuscular? There's a question on that.
Yeah. The growth hormone for normal responder, no effect. Only for poor responder, because growth hormone they can two dual effect. One is there's some beneficial effect for the endometrium I just mentioned, and for fresh transfer you benefit to increase some beta, integrin, alpha B beta 3, some implantation factor with increase. So that will for fresh transfer also good. And also for poor responder, they can increase the pregnancy rate because they can increase a little bit egg number. So egg number not only in young patient, also in old patient. So in young patient, because increased egg number, so pregnancies increase. And also for all patients, when you look at the cumulative pregnancy, also do some benefit. So I think growth hormone is good, but the use is low dose. No, not that conventional use the 3 weeks start from UTF no, please no. I use a start from day 2, day 3, 3 shots, low dose, maybe 4 IU to 8 IU for 3 days. And they can generate the IGF-1 from the liver, and then you can see some beneficial effect. We have done these studies in my clinic for 10 years, phase 1, phase 2, and phase 3, all have positive effect.
Also, does the volume of culture media during embryo transfer increase the risk of RIF?
The volume. Okay, only I think just one drop, not the catheter. Yeah, I think there are different multiple catheter, but altogether, I don't think you can more than 5 centimeters in length. The diameter is very small, so when you eject it out, it's just one drop. Yeah, so I think any kind of medium is okay. But my experience, I don't use. I don't really in favor of using the embryo glue as Keshav just mentioned.
Yes, Keshav?
There's actually a study which looked at low volume embryo transfers versus high volume, where they looked at the load volume. When I say low volume, it was about 20 to 5 microliters that was inserted during transfer, and high volume was about 45 microliters that was put during transfer, and they did not find any differences between the two. This was published in JARC, if I am not mistaken.
And I think that's the translocations in parents also can result in RIF. So is it essential to do karyotyping and
Yes, see, those are the tests which we must do, which are recommended to do for RIF patients. One of the important tests is karyotyping, because if you have a translocation, your numbers may be normal, but if the translocation comes forward, you will have recurrent pregnancy loss as well as recurrent implantation failure. And so one of the recommended is karyotyping of both parents if there is a patient with RIF. That should be done. That is one of the recommendations. The other are the thrombophilia acquired, the lupus anticoagulant and anticardiolipin antibodies. Of this, recently, one rheumatologist told us that LAC is the one. If I had to do one investigation, it would be LAC, lupus anticoagulant, because that is the one which you will find disturbed and causing your thrombotic effects. So definitely, when we are dealing with such a traumatic event for a patient like RIF, these are basic investigations which are not so expensive, and they must be done and cleared. And of course, hysteroscopy has already been mentioned by She, that to look at any anomalies inside the uterus, like a septum or a little polyp or minimal adhesion kind of things. So these are some of the important ones to do. There are others which people do, like the immune, Th1, Th2, or there are certain, I think there's an optimum trial which actually works on the basis of doing the Th1, Th2. So they do the interferon gamma for the Th1 and they do the interleukin 4 for Th2. And if they find that that is altered, the ratio is altered, then they give vitamin D. And if after vitamin D the ratio still remains altered, then they give tacrolimus to actually counter the effect or to correct the modulate the endometrial window of implantation. So, but these are not yet ratified by most societies or most guidelines. So everybody is handling patients in the way by their own thought process and what they feel is important or what they feel is working in their hands. But overall, when we have to give a recommendation or a general outline of how one should proceed, then this actually comes as a last when you don't have anything else and a patient has had multiple failures. Then these are more like empirical treatments which would be tried, the immunomodulators that we have to try. Thyroid antibodies is another one which is important to do. So that should be done.
If you've done a 3D ultrasound and you find everything is normal, would you still do a hysteroscopy?
If a patient has had a failure, definitely I would offer it to them with the information that we may not get anything, but the fact is that if there is something which is undiagnosed on a 3D ultrasound, like some fine adhesions or that kind of a thing, or a micropolyps or some, you can have small micropolyps which you will not actually see on a 3D ultrasound. You're just going to see a nice lining. Now that could be indicative of infection. So you would do a endometrial biopsy for tuberculosis, which is the commonest endometrial infection in our country, and of course for chronic endometritis. So definitely when a patient has had a problem, you would look at all aspects.
So would you also do tests? There are certain tests like ALICE, EMMA, which have come for the chronic endometritis and for microbiome, or would you treat the patient empirically?
See, ALICE, EMMA, two things. ALICE, EMMA are very expensive tests where you're looking at RNA confirmation of these. And then what is the answer? The answer is a lactobacillus. You don't have such organisms with those kind of sensitivities, that they don't give all of that this is the particular organism, this is the sensitivity to that organism, and then you do. So I would rather actually, based on hysteroscopy, which gives you a very good idea of what the endometrium looks like. You can do a histopathology, that is important, do the CD138, do all of that, and you can do your HVS to look for any local infection. And I would rather treat, and I put patients on a probiotic irrespective of anything. I put them, because we know that you can have, especially, when we ourselves are repeatedly doing transvaginal ultrasounds or monitoring, we may be introducing an altered environment in the vagina, which then, goes on to have an altered environment in the uterus. So definitely giving lactobacillus as a probiotic is good. But the tests, I don't find they are cost effective at all in our setting.
You are a great proponent of ERA. So now there's a lot of evidence which is coming which says that it's really of no use. And there's also a question saying that most of the guidelines do say that it should not be done. So can we still consider doing it?
So what I would say, Madhuri, is that guidelines are, you take, somebody does a study and they say something, and then somebody else, and you compound those studies or compute them and say, overall, this is the evidence. But what do you do for a patient who has had recurrent failure with the beautiful blastocyst, with the euploid blastocyst, with the endometrium, all parameters being normal? She's still, would you like to do something? If you're going to give empirical immune therapy, would you like to do a test which would at least give you a transcriptomic of the, or the window of receptivity, so that the dyssynchrony you could correct? I mean, I have reported 5 cases, but I can, give you 30 cases where we have had an endometrial window of receptivity at 3.5. That means literally 1.5, 2 days after you started progesterone. At 7, P+7. These were patients who had 6 embryo transferred, euploid embryo transfers failed in the States, in France, in the Netherlands. And they came here, we did it by ERA, and in the very first shot, they conceived. So you cannot discount that. It may have a limited role, it may have a small role, but I don't think you can discount it. So it depends on you at what level you would want to do it. How long would you want to wait before doing it? That is a decision you have to take. But if I have a euploid embryo, or if I have a low number of embryos, then I will definitely go for the test to see if the window is altered, and at least not waste that cycle and not have to do another whole cycle to, then try to synchronize the embryo. So it has to be your judgment.
There's a question, because you spoke about anti-TPO antibodies. So if there's a normal TSH and the TPO antibodies are positive, so there is a question from the delegates whether we should give thyroxine.
No, thyroxine. So the cutoff which is generally accepted is it should be below 3. Some people say below 2.5 to give any. No. I'm just saying. I'm just giving you a little background. So that is for subclinical thyroidism. That is the baseline which is taken. Now, if your TPO antibodies are positive, the only thing that you have to do is a close monitoring, because at some point in time, that patient may become overt hypothyroidism. You cannot just treat anti-TPO antibodies or anti-TGA antibodies. That is a no. And sometimes I've seen people giving steroid, prednisolone for that. That's not the answer. You can't give prednisolone for anti-TPO antibodies.
So any specific test in the male, because we know that there are certain papers that say that increase in the DFI can result in implantation failure or recurrent pregnancy loss. So would you do it in all the male patients? Would you do a DFI or any other investigations which you would like to?
So I have actually, I don't know. I'm not really convinced that DFI, high DFI is the reason for the recurrent implantation failure, though there is association with adverse reproductive outcomes of high DFI. So I have started doing it, especially where there's history of smoking, alcohol, environmental factors. I do it. I do put people onto antioxidants. Am I convinced that that is the only reason for RIF? I don't think so. But yes, why leave any stone unturned? So we will. I do look at it.
Siri, would you like to give your opinion and any other test you would like to do in the male?
Yeah, I will follow Nalini's comment. Because the autoimmune disease is still present, especially overactive NK cell will reject euploid embryo. And I see several patients with severe adenomyosis. And we look at the antiphospholipid, serum level very high, antiphospholipid, IgM, IgG also very high because the immune response. So for those patients, we should treat with prednisolone or chloroquine so they can diminish the antiphospholipid syndrome. For thrombosis, sometimes you see D-dimer or some a little bit high, but especially if not sky high, maybe a little bit alone, because when we look at those patients with pregnancy, early pregnancy, 6 weeks, 8 weeks, when you look at all the D-dimers, also a little bit elevation, but usually they are below 2, maybe 1.1, 1.5. So if not sky high, just a little bit alone, And the thyroid is very important, thyroid function. Hyperthyroidism will end up with miscarriage, hypo-infertility because no ovulation. But TPO is an antibody that's lifelong, so it cannot go away. So once the patient has some thyroid, such as Hashimoto disease, sometimes the TPO is lifelong, so just leave alone. But some publication describe if the TPO high, maybe add some small dose of etroxin, that's a thyroid hormone, maybe some beneficial, but I think it still needs some studies. For some uterine disorder, fibroid adenomyosis, usually you see the uterine contraction is very often after transfer. So in that case, there's some publication for uterine fibroid during transfer, 30 minutes before transfer, you give the patient some atoxaban, which is an oxytocin antagonist, so it can diminish the uterine contraction. So maybe some beneficial for further implantation. And also, I think the hydrosalpines, if that is the case, I also recommend do the PTO, proximal tubal occlusion, before transfer, because the toxic fluid they can release from the hyposalpinges and the influx to the uterine cavity, which will impede or interfere implantation. So that's we have to take care of those problems before transfer.
So there was a question, Keshav, to you as to, that euploid doesn't tell us the whole story about the embryo. When would you consider the whole exome sequencing? And is there a role at all? And after excluding endometrial receptivity is a cause?
Very interesting question. I don't think I know about whole exome sequencing being used for embryo transfers or embryo selection. The comment is correct that euploidy does not tell us the whole story. There could be certain times with especially balanced translocations, etc., that we would not be able to diagnose embryos and those patients might result in miscarriages or implantation failure. So maybe PGT-SR is something that could be recommended for this particular group of patients. But whole exome sequencing opens just a very big box of its own challenges, because here then we might find incidental findings which, though not significant enough, might restrict us from using the same embryo for transfer. I I don't really have any experience or evidence to suggest this use. Maybe the others can comment on this.
Well, I think you're right. It's a Pandora's box because there are so many mutations, non-significant, which have not had any impact on the person, which come up, and I think they just scar them for life because it's always there that I have this thing, of a mutation which may cause hereditary deafness. So this I've had this recently in my patients. So it just takes you nowhere and actually creates a lot of anxiety in the person because now they know that they have a certain mutation in them. So I really don't know when is the right time to use
And if
this.
it's something that's identifiable in the parents,
Then
Right.
probably
then
it's absolutely.
Then you can
definitely
do a PGTM, but
PGT-M can be done. But
otherwise,
otherwise,
just
doing it for the embryo honestly doesn't make sense as of.
So there's a question saying that a male 45 years of age, no varicocele, poor DFI of 80, grade 4 renal medical disease after 4 IUI failures, planning for IVF. How to improve the DFI? Already male is
they
on
can do a
toxin.
varicocele repair. Yeah. If he has a grade 4 varicocele, it should be repaired. That will improve the
No,
DFM.
no, no, no varicocele. Grade 4
Renal,
Oh,
right?
renal medical disease.
renal disease.
I mean, generally
And do
antioxidants
testicular,
that you
what about
try
a
and
TESA? Yeah?
yes. And
Test.
first is antioxidants for at least 6 months, and then if
No,
it is
he's
still
already
not,
on antioxidants.
They can do
surgical
a TESA, that is
retrieval,
the easiest way out.
surgical sperm retrieval can be thought.
Yeah. So I think even lifestyle modification is a very important factor when you talk about RIL. So that's the most that has to be advised in all patients. And how would you treat the other factors like the endometrial factor or the thin endometrium?
Well, currently, what I am doing for thin endometrium is I use intrauterine PRP, and that works very well. From she, I learnt the use of growth factors for thin endometrium. So, see, up until 6.5, I don't worry that those patients conceive as with a nice trilaminar lining. If it is inherently like that, they conceive. But one important thing is to continue their estrogen in the early phase because the trophoblastic invasion, because of the thin endometrium, that is an issue and they land up more into early abortions. So even in a spontaneous person who conceives spontaneously and has had a thin endometrium, I do carry on their estrogen for a while and it helps. But when the endometrium is below 6, those are the difficult ones. And their repeated HRT cycles, repeated cycles of intrauterine PRP and growth factor, she said, they do help to improve the endometrial lining. After, of course, you have ruled out adhesions and other stuff.
Now there's no evidence for the endometrial scratch or injury or intrauterine HCG administration, what they said, and GCSF.
I
Or
never believed in endometrial scratch ever. When it came out, we tried and I realized that it's of no use. So I don't do. I don't
CG,
know
what
about
do
the
you
others.
think,
The
Professor Chiri?
endometrial, the endometrial scratching is only useful for previous failed implantation. That's published, I think, in New England Journal of Medicine from Hong Kong's group, only for previous failed cycles. And for very thin, resistant thin endometrium, I think PRP, sometimes they can do some positive effect because we have some cases uses PRP, and then we see the a little bit growth, okay, compared with the control. Some increase the thickness of the endometrium. And some audience, the delegate asked the audience asking the intrauterine growth hormone placement. Probably is no. You should be go to through IGF for liver. So PRP is more effective, direct effect to the endometrium, but not a direct growth hormone into the
Is
uterine.
there a role basically for any vaginal sildenafil in endometrium, and whether you need to give anticoagulants like aspirin and low molecular weight heparin to all patients of RIF, or would we give only to those who have thrombophilia and who have lupus anticoagulant ANA positive or APLA positive?
Theoretically speaking, use the low dose aspirin, small dose aspirin, because they can increase local blood flow, blood circulation. So there may be some good effect, beneficial effect to the endometrial growth. So I agree this point. And also for some patients with the normal TSH but positive anti-TPO antibody, we published in Human Reproduction positive anti-TPO and use low dose thyroxine 1 month, starting from 1 month before transfer. There's some beneficial effect. Small dose, only small, that's 0.25 microgram, small dose. Need more studies.
Yeah, we know our stimulation effects, so many people are therefore going for frozen embryo transfers in all patients. But now there's a lot of evidence coming that FET for all should not be done and should be done only in indicated cases. So what is each one of yours on that?
I completely agree with this statement that FET should not be done for all patients. We are still doing about, I would say, 40% fresh transfers in our clinic. The only reason we do an FET would be if either the endometrium is not great in that cycle, or it's a slightly higher ovarian response as what we would like it to be, or the patient being adamant that they would not want a fresh transfer. Uh, in other scenarios, we do fresh transfers. There is a decent pregnancy as well as a live birth rate in these cycles. And most of our patients are also non-affording, so it does not make sense to um, charge them more and then do a frozen embryo transfer cycle.
Keshav, does sperm selection help in patients with RIF? Any particular method?
I would only say that if there is a finding of high sperm DNA fragmentation in a particular patient, that is when I would utilize sperm selection as a modality. We are currently using microfluidics as well as physiological ICSI for such patients. I have done a comparative analysis of pre and post DFI for microfluidics, and it's actually very, very good. Post the use of a microfluidic device, almost 90 to 95% of sperms are having an intact sperm DNA, which is quite reassuring for us, because then we are confident of just going ahead with straight ICSI or even with IVF for such patients if the device allows it. And for Pixie, again, this was I did a study in 2016, which I presented at Aspire itself, where we did find a positive correlation where DFI was high and we compared ICSI versus Pixie.
Yeah, but in my experience, I mean, Pixie really did not help in improving the implantation.
There's no evidence to suggest. The paper in Lancet also says that uh, the miscarriage rate might be lower in Pixie selected cycles, but again, cumulative live birth rates and live birth rates were not statistically different, which I just don't understand how that was possible, because at one point they're saying miscarriage is lower, but the other point they're saying live birth is the same. So I don't know.
The most important question is now many people are just using many immunological treatments. So we have several treatments, like you have the corticosteroids, you have IVIG, then they also use the peripheral mononuclear cells then you're having intravenous intralipids, then you use many anti-immune drugs like tacrolimus and the TNF-alpha blocking agents and all. And some studies also have shown hydroxychloroquine, because I see many patients who have been having RIF and treated outside come with air on hydroxychloroquine. So I would like both Chiri and Dr. Nalini to give me a opinion on this.
So, with this hydroxychloroquine, I had a very long chat with my endocrinologist, and it is, if the CRP is raised, okay, so it suggests inflammation. And in those patients, HCQ is supposed to help, and we have been using HCQ after if the CRP is raised in a patient of RIF. I don't do it routinely, and neither do I routinely start it for transfer. But if in a patient of RIF CRP is high, I do give it. So far as the other immune therapies are concerned, I think it's a roll of a dice or a flick of a coin. To be honest, none of them, there is no evidence with most of them of any benefit. But sometimes, because a patient has had so many failures and they ask you as to what you are going to do which might benefit, then in that case I normally used to like and I still use GCSF, but I have used intra IVIG in 1 or 2 patients, very little use and exposure, because I'm not comfortable with it. I really don't know how well it works, and therefore I'm a little reluctant to use. Same is true for intralipids. Again, if the patient asks, but I'm not convinced personally that it is of great help. So it's all out there. The only thing that you do know is about the inflammatory marker. If something is positive, then maybe giving HCQ will help. Again, if we are trying to do the uterine NK cells, the biggest problem is that they are not quantifying the cell number. So unless you have a quantification of the uterine NK cells, because the uterine NK cells are going to be there, so unless you know what is the right quantity in the proliferative and right quantity in the receptive phase, how will you treat that? So that's a big question mark. But sometimes when there is a history of autoimmune disorder in the patient, then I do use prednisolone only if there is a history. So that is based on if there is a positive history, and of course if there is a positive LAC and all, then you use the low molecular weight heparin and aspirin. So these are the 2 things. And now the new drug that has come in is thymosin. From the thymus they have the extract, thymosin alpha. And I really don't know. I'm running a trial now, just started, and doing some baseline tests, and then doing that, and let's see how it works out. Though, it's a big question mark at this point.
Piri, would you like to add something? Immunotherapy?
I think the real immune disease, not so many, unless you prove. Otherwise, we don't use. I have one patient, the rheumatology doctor asked the patient to take a hydroxychloroquine every day after transfer. But I stopped. I asked him, because there's no evidence of thrombosis panel study as well as the antiphospholipid panel study. All are normal. So I asked the patient stop all the treatment, and she had lab births. The other patient, the rheumatology doctor also asked him to have IVIG every week after pregnancy until delivery. So this is empirical study. So I am reluctant, just as Nani said, reluctant to tell him to stop this medication. And she continued to use IVIG every week until finally she still delivered. So I don't know whether if I ask him to stop the medication, still have lab births, but it's very hard to do this retrospectively. So I think it's a mystery. It's still very difficult. I am not quite convinced until you tell me all the profile of the antiphospholipid profiles, thrombosis profiles goes up. Otherwise, I don't. But I rarely see all these profile goes up altogether. Very few. Only one item or in the borderlines. For example, antiphospholipid test borderline, and then I don't think it's meaningful.
So now we have almost crossed our time. So I would like one concluding statement for each of my panelists. So we can start with Keshav.
I would actually say that if we follow the guidelines and do the things that are advised in the guidelines properly, ensuring that quality control is followed for each and every step, especially within the laboratory, like basic stuff like doing a proper semen analysis, doing a proper embryo culture, dish preparation, maintaining your laboratory, etc. Because here we are talking about a very small subset of patients, which is RIF after euploid embryo transfer. This is when all of these external parameters, which are in our hands, can actually contribute to a loss. So just try and ensure that you do your best within the laboratory and hope for a pregnancy.
Dr. Nalini?
Stumped. I don't know how to answer this question, but what I would say, I'll say what I do. And I take even one implantation failure where everything has been good, because my evaluation of the patient is very thorough before even I get started with an embryo transfer. I would have checked out, as we all do, the ultrasounds are done, the anatomical stuff is ruled out, thyroids are all done. And in my case, before I do the embryo transfer, because in the north tuberculosis is very rampant, we do an endometrial biopsy to rule out tuberculosis, especially if there is a family history and there is pelvic fluid or whatever. So all of that is done as a total routine before we even attempt embryo transfer. So the only things now left, if a patient has had embryo transfer failure, even in the first embryo transfer failure where the endometrial lining is very good, then the next step really is to go towards doing the antiphospholipid antibodies, to do the hysteroscopy. And there again, when I discuss it with the patient, I tell them I'm not very certain how beneficial it will be because you have a fantastic lining. However, because you've had a failure and we really can't account for that failure, well, then these are the tests that we need to do. So I think we have to go in a graded stepwise manner and just rush into every kind of immune therapy that is suggested. I think that is where we have to hold back and not get tempted to do that, because it ultimately really leads nowhere.
Kiri?
Yeah, I think the endometrial receptivity issue is important because the timing of embryo transfer is critical. If the endometrium is not the right phase, receptive, it may not be proper support the implantation. And also the disease such as endometriosis, polyfibroid, and adenomas, you have to take care of this. Use the atoxaban, use the GnRH, etc. I think endometrium you can take care of, use the, probably use the growth hormone, or use the PRP, or use gel. Sometimes you plus oral estrogen and gel ointment. Sometimes it use a dura effect. For chronic disease, look at the chronic endometritis and identify this disease and treat it. And immune factors, very complicated. Yeah. So until you have solid evidence or the antiphospholipid syndrome or some thrombosis criteria goes up, otherwise, very careful to take care of this patient. NK-cell, just Nali say, is very hyperactive. You have to treat with some proper medication. The anatomical factors such as septum, the hysteroscope can take care of Asherman syndrome. You can take care, and also the microbiome, probably to increase the lactobacillus population, and then it can increase pregnancy rate.
I think just one thing, Madhuri, I'm sorry I should have added, and I think that is one aspect we completely missed discussing, was the luteal phase progesterone levels. I think it's very important. I do it as a routine on the day of embryo transfer for every single patient and add In our unit, we've seen below 15 nanograms, we have higher miscarriages. So we try to keep it above 15. I think that
I agree, but my opinion is 10, more than 10 nanogram after transfer is
yeah.
enough. 15,
For us, we found
I
in our this thing it was 15, so we keep it
I
at
was
15.
less than 8, very dangerous. Less than 10. So you have to add some oral different approach, not oral, maybe vagina approach. 2 approaches better than 1 approach to supplement the progestin.
So I think it's basically the personalization of the fertility treatment depending upon the individual patient characteristic is most important in recurrent implantation failure. And I mean, we cannot say that this particular treatment or investigation will work for all patients. So I think personalization is very, very important. And before I end, I would like to thank Professor Chiri, Dr. Nalini Mahajan, as well as Dr. Keshav Malhotra for being here for this webinar. And I think they would have answered most of the questions the delegates have.